to have with us a very esteemed faculty in neuro-ophthalmology, Dr. Rashmin Gandhi with us, who is a very dear friend and a very kind, gentle human being. We are very, very fortunate and we want to welcome Dr. Rashmin Gandhi. I'd like to give a brief introduction of Dr. Rashmin. He has done his double FRCS, one from Glasgow and one from Edinburgh. He is also a director of Foresight Worldwide, which is a company which helps hospitals internationally. He has done his ICO fellowship from Johns Hopkins University. He is a consultant neuro-ophthalmologist at Center for Sight at Banjara Hills in Hyderabad. He is a visiting professor also to the University of Hyderabad, and he is the vice president of the Indian Neuro-Ophthalmology Society. He was the director at Shankar Nethralaya Academy also, and was in Shankar Nethralaya Chennai from 1995 to 2013. He is very well known nationally and internationally, has several publications and has written many chapters in different books. I would like to welcome Dr. Rashmin Gandhi today to teach the postgraduates. Welcome, Dr. Rashmin Gandhi.
Thank you so much. Thank you, Satyajit. It's always a pleasure to interact with you, and your energy is so infectious. And I'm extremely thankful to you for making me part of this wonderful series that ABI Institute Patna has conducted. And I have been following it, and I'm seeing all eminent faculty teaching the postgraduate. So extremely thankful to you, Pooja, and everybody at ABI Institute Patna. So let's get going. Today's topic is a little complex topic, but an important topic for all the postgraduates. And I'll be very happy if the postgraduates who have joined here can, it's going to be interactive, so they can write their answers in the chat or even unmute yourself and you can answer. So before I start sharing and showing you a video, let's have some platform before we go to the real cases. So when somebody has an ocular motility problem, what is the most predominant symptom that he's likely to experience? Any postgraduate who have joined here, you can answer by unmuting yourself or you can write it in a chat. What's a predominant symptom of somebody who has an ocular motility problem? Any idea? Is Dr. Abhishek or Dr. Vishwanath Pratap, who have joined now, are you here?
Yes, sir.
Yeah. So what do you think?
So
what's
diplopia.
the most fantastic, extremely correct answer? Even Dr. Abhishek has written here that the most prominent symptom is likely to be diplopia. Now, stay here and also tell me that if patient complains of diplopia, what is the first question that you'll ask the patient?
Uniocular, binocular.
Fantastic. Monocular, binocular. Why would you like to ask that question? What information it'll provide you? What's the difference? In other words, what's the difference between a monocular diplopia and a binocular diplopia?
So in uniocular diplopia,
yeah,
the palsy lies in one eye, which when it's closed eye, the affected eye when closed, then the patient will able to see normal. But if the binocular diplopia, then patient, even if one eye is closed, then also he will see double vision.
No, so there is a slight change here. Please remember that when you say binocular diplopia, what it means is that diplopia will disappear when patient closes either of the eye. Does not matter which eye has a pathology. But if the patient has a binocular diplopia, if he closes either of the eye, diplopia will disappear. While in monocular diplopia, let's say patient has a diplopia. Monocular means he is having diplopia only through one eye. So if patient has a diplopia through the right eye, even if the left eye is closed, the diplopia will not disappear. So monocular diplopia is diplopia present in one eye, which will not disappear even when you close the other eye, while binocular diplopia will disappear when you cover either of the eye. The reason why you want to differentiate between the two is binocular diplopia will always occur because of ocular motility problem. When patient has a squint or both eyes are not moving synchronously is where patient will have binocular diplopia. While a monocular diplopia almost always originates from the eye. Somebody who has cataract, the commonest cause we come across is cataract, astigmatism, corneal problems, subluxated lens. These are the causes of a monocular diplopia, while a binocular diplopia will be because of an ocular motility problem. Very rarely, a monocular diplopia can also be neurological in origin. So can you tell me how would you differentiate if a monocular diplopia is because of a neurological origin or an ocular origin? Can you perform a simple test, clinical test? Any test that you can perform in the OPD? Simple test. All of us have done that test. So the test that you can perform to differentiate between a monocular diplopia from the ocular origin from the neurological origin is pinhole test. So neurological diplopia will still persist if it's monocular in origin, even if you put pinhole in front of that eye, because it's originating from the cortex. It's a rare thing, but it's a theoretical discussion which sometimes examiner would like to ask you. While an ocular diplopia which comes because of cataract or because of an corneal problem would disappear when you insert a pinhole in front of that eye, right? So very good. The commonest symptom of an ocular motility problem is diplopia, and the most important question is whether diplopia is monocular or binocular in origin. All right. Any other question? Anybody else would like to answer? Dr. Paul or Abhilasha or Mamta Singh or Dr. Kanji, would you like to say what about monocular and binocular? Any other question that you'll ask somebody who complains of diplopia? All right. So the second question that you would like to ask is whether diplopia, which case, very good. Dr. Abhishek, you are doing well. You also answer that question on the chat, that which case diplopia is more, whether it's more on the right side, left side, up or down, which will give you some kind of indication as to which muscle or nerve is likely to be involved. And the third important question in diplopia is there any diurnal variation? Is diplopia more in the morning, more in the evening? Does it change with the activity? Now, why that question be important? What disease you like to rule out if there's a diurnal variation?
Myasthenia gravis could be.
You can, so that I can ask you the next question as well.
Sorry, sir.
What's your name?
Sir, Ruchi Saxena.
Very good. Ruchi, so this is myasthenia gravis. The diplopia will be more in the morning or in the evening?
So more in the evening. They will be.
Are you aware of any condition where diplopia will be more in the morning when the patient wakes up? It will go away once after some time.
If patient tries to accommodate, then he will the diplopia will go away. Sorry, I can't.
Yes, you're right. See, thyroid ophthalmopathy, sometimes the diplopia can be more in the morning. Also, patient who has a fusional problem. So when he has taken a rest, when the eyes were at rest, when he wakes up, he'll take time before the fusion kicks in. So that's where he will have diplopia in the morning, and once he starts working, the fusion, the convergence comes in, and he'll be fine. Fantastic, great. So that's about the symptom trilogy. Now let me ask you one more question before we start going on to the cases. What are the different types of ocular motility that you know of? Dr. Saxena, you can answer that. What are the types of ocular motility?
The uniocular movements and binocular movements.
All right. Okay. Anything else? What are the fast eye movements called? What are the slow eye movements called? Yes, Abhilasha, you're right. Versions and adductions in the chat. Fast movements are called. It's fantastic.
Saccade.
Yes, and the slow eye movements? Pursuit. Fantastic. Any idea as to which area of the brain controls saccades?
Yes, sir. Pursuit is controlled by the ipsilateral frontal, and the saccade is controlled by contralateral frontotemporal.
All right, you mix it up a little bit. So saccades are controlled by contralateral frontal lobe. Saccades are controlled by contralateral frontal lobe, while the smooth pursuit is controlled by ipsilateral parieto-occipital region. Now, so that's the basics of ocular motility. You should know about diplopia because that can be asked either as a short note or you'll be asked in a viva about the questions related to diplopia. And the second is about the different types of movement. At the end of all the cases, I'll go back and cover some of the complicated movements which sometimes we don't talk about, but they are nonetheless important from the theory point of view. Let's now get to the cases. All right, so I'm sharing my screen and you will start seeing my presentation. All right, can you see my presentation here?
Not yet. Now we can.
All right. So let's go to some of the interesting cases of ocular motility. All right, one of you have a look at this video carefully and tell me what you find. This is a 37-year-old gentleman who came to you with the complaints of double vision. See what happens when the patient tries to look to the left.
Video is not running.
No, it's running, but I think it's running quite slow. Yeah, okay, let me skip this video. We'll come back to this video a little later. Let's see if this runs properly. So this is a 67-year-old gentleman who comes to you with a double vision. Now see what happens when the patient follows this pen to the left and when the patient follows the pen to the right, to the left and to the right. Assume that the vertical movements are normal. What did you see?
Left eye, left lateral rectus pulses.
All right. So I think in the exam scenario or anywhere, the first thing you should ask yourself or tell yourself is that this patient has a left limitation of abduction. Don't use the word restriction of abduction because restriction implies a pathology, a particular pathology. You should always say that patient has limitation of abduction of the left eye. Fantastic. And the most common cause, obviously, as you very rightly said, is a lateral rectus palsy or abducens nerve palsy. Fantastic. Great job. Now, if you say this patient has a left 6 nerve palsy, can you think of anything else which can cause an abduction limitation before we go on? What are the other causes of abduction limitation?
Type 1 Duan rejection syndrome.
Yes.
Type 1 Duan syndrome.
Yes. What else? What if I say patient had a trauma?
Sir, and then can we
there can be entrapment of the medial rectus, which will not allow the eye to abduct, right? If the commonest areas of the orbit which get fractured because of trauma are first is floor of the orbit and then the medial wall. So there's a medial wall fracture. There'll be medial rectus which will get into the medial wall and will not allow the eye to abduct. That's something which is very important to know. The other causes can be if there is a fibrosis of medial rectus, or if there is inflammation of medial rectus, that also will not allow the eye to abduct. So abduction limitation, 6 nerve palsy is the commonest. Patient can also be having Duane syndrome. He can also be having entrapment of muscle because of the fracture, or he can be having some other muscle problem, myositis, which can be because of cysticercus or inflammation, which will not allow the eye to abduct. Very good. Let's assume that this patient has a 6 nerve palsy. What would you do next? What's the next step? So this is how you check the smooth pursuit movement, right? Patient is following your pen. All right, what would you do next? If you say patient has a 6 nerve palsy, what next?
check for other ocular movement. We'll check in all gaze, sir.
Yeah, which we have done now and assume that they are fine.
So now vertical is fine, so it is a horizontal gaze palsy.
No, it's not horizontal gaze palsy. It's an abduction limitation only. Horizontal gaze palsy is a different problem altogether. We'll come to that later. So there's an abduction limitation, 6 nerve palsy. I'm telling you that this is a 6 nerve palsy. What would you do next?
Investigate the patient. for the cause.
Fantastic. What? Yeah.
So
What?
we'll diabetes. First, we'll try to know whether patient is diabetic or hypertensive, and also do an MRI brain.
Okay. All right. So please remember, what you're saying is right, but obviously a clinical examination would be the cornerstone. That should be your first answer. So if you say that yes, patient has an abduction limitation, commonest cause seems to be sixth nerve palsy because there is no history of trauma, there is no lid movement to suggest that this is Duane syndrome. There is no pain to suggest that there can be fibrosis or inflammation of the muscle. So this looks like a left sixth nerve palsy. So a first thing that you'd like to know is this an isolated sixth nerve palsy or are other nerves involved, other related nerves? You're not interested in accessory, spinal accessory nerve or an hypoglossal nerve directly. Of course, they are also important. But the first thing is the nerves which are in immediate vicinity of the sixth nerve, are they all right or they are also affected? Because if they are affected, then you're looking at a structural lesion along the course of the sixth nerve. If they are fine, then you're looking at an isolated sixth nerve palsy. So what are the cranial nerves which are in the vicinity of the sixth nerve throughout the course? You remember in the anatomy diagram,
Fourth nerve.
what is the sixth nerve nucleus?
So when is the fourth nerve which? So the pons.
Facial nerve, sir.
Facial nerve. Excellent, excellent. Who said facial nerve?
Dr. Akshay.
Akshay, fantastic. So facial nerve. Now, Akshay, you have to tell me which areas along the course of the sixth nerve where sixth and the seventh nerve, abducens nerve and the facial nerve, are in the vicinity. There are two areas along the course where these two nerves are together.
Their nuclei are close together in the midbrain.
Not in midbrain, in the pons.
Pons.
Yes, midbrain is third and the fourth nerve.
Yes,
Sixth and the seventh nerve are the pons. If you remember the diagram from your anatomy days, you will find that the seventh nerve makes a loop around the sixth nerve nucleus to form what is called as facial colliculus. So sixth and seventh nerve are together in the nuclei and the nerve is together in the pons where they originate from. And the second area where they are together is CP angle, cerebellopontine angle. Okay. Now, Akshay, would you be able to tell me clinically what would be different if sixth and seventh nerve are affected because of a lesion in the pons where the nuclei are involved, or when their sixth and seventh nerve are affected because of a pathology in cerebellopontine angle? Would you find any difference in your clinical examination if the areas are different? Ruchi, Akshay, anybody can take this. So please remember, if the problem is in the pons, so we are talking about a scenario where sixth and seventh both are affected. So if the problem is in the pons, then remember sixth nerve nucleus acts as a gaze center. So if sixth and seventh nerve are affected, and if the problem is in the pons, then you will find that patient actually has an ipsilateral gaze palsy. When the sixth nerve is affected, you will have an abduction limitation only on the same side. So if there is a left sixth nerve palsy, you will find there is that left eye is not able to abduct. But if there is a left nucleus problem of the abducens nerve, you will find that the patient is not able to look towards the left at all. That means the left eye is not abducting and right eye is not abducting. Why this kind of picture you'll see is because the sixth nerve with...
We are at the same slide.
Yeah, I have not changed it.
Okay, sorry.
And so sixth nerve nucleus is in the vicinity of a tract called PPRF. What is PPRF? So PPRF is parapontine reticular formation. And it yes, so it controls the gaze to the same side. So if it's a problem with the pons, if it's a nucleus of the sixth nerve which is affected, then patient will have gaze palsy to the same side. Now contrast it to a pathology of a CP angle. In a cerebellopontine angle, what you'll find is that the gaze will be fine, but let's say if there is a problem with the left CP angle, what you'll find is that the left eye is not abducting, left facial nerve also is gone, right eye will adduct, but in all probability, you'll also find nystagmus of the right eye because of the cerebellar involvement. So remember, if you see a patient with the sixth nerve, first thing you want to do is to find out whether the nerves which are in the proximity of the sixth nerve, whether they are affected. The first nerve you'll always think of is a facial nerve because they are in close contact in the nucleus, in the pons, and in CP angle. If the problem is in CP angle, you'll find that the gaze is fine, sixth and seventh nerve are affected, but the other eye may have a nystagmus. If the problem is in the pons, in the nucleus, then you'll find that there is a gaze palsy. Apart from, let's say, problem is of the left side, apart from the left seventh nerve palsy, you will find that the patient is not able to look towards the left side. This is an important distinction. So sixth and seventh nerve together. Which is the other nerve you're thinking of? You come closer to the eye now. What are the other nerves which are in proximity with the sixth nerve?
Fourth nerve.
Fourth nerve, yes.
Third nerve.
Third nerve. Which number is missing now? Third, fourth, sixth, seventh.
Fifth, ophthalmic branch of this system.
Yes, so you're looking at third, fourth, fifth, sixth, and seventh. You already know that problem is with the sixth. You want to know whether third, fourth, and seventh, third, fourth, fifth, and seventh are affected. Seventh we discussed. Now we come to the fifth nerve. What are the ways by which you can examine the function of the fifth nerve?
Corneal sensation.
Fantastic. You look at the corneal sensation. Also look at the sensation on the face of the side. And what about third and fourth nerve? Which are the areas in the pathway where third and fourth nerve are together? Third and fourth nerve together?
Cavernous.
Somebody who is speaking Bengali, they can mute their mic because the conversation is not related to the presentation appeal. All right. Yes, cavernous sinus and any other area? Also in the orbit. Third,
Orbital apex.
Yes. Now, can you differentiate between the orbital apex problem and the cavernous sinus problem by simple test? One test. So you always look at the optic nerve. If the optic yes, visual acuity. If the optic nerve is affected, not affected with the cavernous sinus problem. Manish, can you mute? I think there is somebody whose mic is on. So let me show you the.
सबको म्यूट कर दीजिए और उसके बाद फिर जिसको बोलना होगा फिर अनम्यूट करें.
Okay, sir.
Now we will check the saccade.
Rashmin sir, now you can unmute your mic. I have muted all.
Rashmin, you can unmute yourself.
All right. Can you hear me now?
Yeah, we can hear you. Now the slide also has come back.
All right. Okay. So what we're discussing was that third nerve, fourth nerve, fifth nerve, they are all in the vicinity in the orbit and in cavernous sinus, and sixth and seventh nerve are in the brain, mainly CP angle and the pons. And to differentiate between the orbital lesion and the cavernous sinus lesion is to look at the optic nerve. The optic nerve would be affected in most instances where the lesion is within the orbit or at the orbital apex, while in the cavernous sinus lesion, you will have a sparing of the optic nerve. Now let me show you how you check for saccades. These are the testing of saccades. Patient is looking at the pen and looking at your nose. Looking at the pen, looking at your nose. So saccades is the fast movement where you have a target outside fovea and then patient quickly looks at you. So that's how you check saccades. While the smooth pursuit is when patient follows a slow moving target. So that's how we check the smooth pursuit. What we are testing right now is saccadic movement, always tested in horizontal gaze and tested in a vertical gaze. All right. So that's about motility examination. You'll also find which nerve we are testing now? Yes, you are asking. These are some of the tests that you can do quickly to see whether seventh nerve is affected. Which nerve is being tested now? What did I do with that? Near the ear I did something. So that's a rustling sound in the ear. That's a quick way of seeing whether eighth nerve is also affected. Because remember in CP angle, acoustic neuroma is one of the common lesion in CP angle, which can present you with a sixth nerve. Patient would have a simultaneous involvement of the seventh nerve and also the eighth nerve. So eighth nerve you will be able to uncover by seeing whether patient is able to hear. All right. So that's about the abducens nerve palsy. So see what happens when the patient looks to the left. Can you see that left eye is not going completely towards the left? Again, an abduction limitation, the left eye. So what's the difference between a gentleman that we saw in the previous video and this video? Obvious age. The previous video gentleman was around 67. This gentleman is around 25. So is there any difference if you find a sixth nerve palsy in a young person versus an old person? Any particular difference? A very important difference. So the difference is, in a young patient with a sixth nerve palsy, you always think of a tumor first. Even if the patient has diabetes or blood pressure at a young age, you always have to rule out a space occupying lesion along the course of the sixth nerve, because that's the commonest cause of a sixth nerve palsy in somebody who is below the age of 40. While somebody who is above the age of 40, 45, the commonest cause would be hypertension or diabetes, as Dr. Saxena mentioned. So if you find a young person with a sixth nerve palsy, even if it's an isolated sixth nerve palsy, you ruled out third, fourth, fifth, seventh and eighth nerve, even then you will ask for MRI brain and orbit. Versus somebody who is above the age of 65 and he has an isolated sixth nerve palsy, third, fourth, fifth, seventh, eighth nerve are fine. No other neurological symptoms or signs, no headache, no other weaknesses of the limbs. Isolated sixth nerve palsy with a known diabetes or hypertension. Those patients you can observe. You need not do MRI all the time, but if you are not doing a neuroimaging, then you should call the patient back every week and perform all the tests to make sure that the other nerves are not getting affected. So that's the difference. Older patient with a vasculopathic risk factor, isolated sixth nerve palsy. This is an extremely important statement. Isolated sixth nerve palsy you can observe. If other cranial nerves are affected, obviously you have to do neuroimaging. Versus a young patient below the age of 40, does not matter whether the patient has a vasculopathic risk factor. Patient should be, everybody who is below the age of 40 should be getting a neuroimaging. In fact, we had published this paper in IJO when we did the study in Chennai a few years ago. So that's about sixth nerve palsy. Now let's see what you are able to find in this gentleman. One of you can describe, once you have seen the video, patient looking to the right. This is patient looking to the right. And now patient looking to the left. This is patient looking to the left. What did you see? You want me to play the video again? Patient looking to the right. So this is patient looking to the right. And this is patient looking to the left.
Both high limitation of abduction.
What did you find in the right eye when the patient was looking to the right? So this patient had a bilateral 6-nerve palsy. Have a look at it again. Could you appreciate it? Bilateral abduction limitation. So what would you do next? Patient having a bilateral 6-nerve palsy, what would you do next? I think whosoever wants to answer can unmute themselves because all mics are muted. Manish, can you unmute people now, I think, so that they can answer?
Sir, unmute might rights they have their own, sir. I cannot unmute from here. Participant need to unmute themselves.
Any idea about what would you do next when there is a bilateral 6-nerve palsy? Is there any other cause of the 6-nerve palsy that we are missing out? So one cause you should always think of the 6-nerve is raised intracranial pressure. What is it called? Involvement of the 6-nerve or a 6-nerve palsy in a raised ICP. What is it called?
False localization.
That's called false localization.
False localization.
Right? And why would you see a false look? Why would you have a 6-nerve palsy as a false localizing sign in a raised intracranial pressure?
Because of the long
Why
course.
6-nerve is affected when there's a raised ICP? Anybody?
Because of the long course of the 6-nerve, there's stretching of the 6-nerve.
Dr. Ruchi?
Because
Whoever wants to answer can unmute because the administrator has muted everybody.
because of the long course of the 6-nerve, there's stretching of the 6-nerve.
So this, yeah, any idea?
Because your ankle herniation.
No, not ankle herniation. Anything else?
Because of the long course of the 6-nerve, there's stretching of the 6-nerve in raised ICP.
Yeah, so that's a commonest answer which is given, that because it has a long course. But please remember, 6-nerve course is not the longest through the brain. Which nerve has the longest intracranial course? It's actually trochlear nerve. Yes. So now question comes in, why 6-nerve is more susceptible when there's a raised ICP? The reason being because the way it reaches the orbit, it is in touch with, let's say, petrous apex, it is in right over the bone. So if there is a pressure, the 6-nerve gets pressed against the bone, and that's why it gets affected more commonly in raised ICP. So this is called a false localizing signs. What next test would you like to do if you see a bilateral 6-nerve palsy in somebody who has complaints of headache? What would you like to see next, immediately?
Fundus examination.
Fundus. You are looking at this edema. Absolutely right. Fantastic. All right. So now let's look at this gentleman and see what do you find here. So patient looking to the right, up, down, to the left. What do you think? Yeah. Any idea?
A complete ophthalmoplegia.
Exactly. So there is no movement which is present. And as we said, in this patient, you like to see whether patient's vision is fine. whether the patient's optic nerve is okay. If the vision is fine, this is likely to be behind the orbit. And if the vision is affected, this is likely to be somewhere within the orbit. So that's how we differentiate. So please remember, if you see a patient with an abduction limitation, the problem can be in the orbit, where you'll find second nerve, third nerve, fourth nerve, and fifth nerve to be affected with the sixth nerve. It can be somewhere in cavernous sinus, where again third, fourth, fifth can be affected, but the second nerve will be spared. Somewhere along the line, near the pons in CP angle, sixth and seventh nerve would be affected. Sometimes fifth and eighth also can be affected in CP angle. And in the pons, it'll be sixth and seventh, but it'll have a coexistent gaze palsy. So that's about the abduction limitation and the sixth nerve palsy. Now look at this gentleman. What's the first impression? Patient has a right eye.
Ptosis.
Right eye ptosis. Anything else are you seeing? Anything? Any other? What do you see here? Okay. What's your observation? Right ptosis. You see there is a scar here.
Trauma.
Sorry? Patient has a third nerve palsy, and the most likely cause is this trauma. But it can be something else as well. What is the immediate, what is the other information that you like to know about this patient? If somebody has a third nerve palsy,
Pupil involving or sparing.
fantastic. Why would you like to rule out involvement of pupil? What is the clinical significance?
So whether it requires surgical intervention or not.
Not, I mean, a better way of responding that, because since we are not a neurosurgical or a neuroradiological experts, our concern is that, is it something which is compressing on the third nerve, because that's most likely to cause involvement of the pupil, or is it because of ischemia of the third nerve? Now, why that is important? What is one of the commonest causes of compression of the third nerve?
Aneurysm.
What's the communicating artery? Aneurysm.
Aneurysm where?
Posterior communicating artery.
Fantastic. Posterior artery aneurysm is the commonest compressive lesion of the third nerve, which can present to you with a third nerve palsy with anisocoria and a larger pupil on the affected side. The reason why this is important to know is because this aneurysm can burst and can give rise to subarachnoid hemorrhage, which can be fatal in 50% of the patients, and the rest would have a permanent neurological deficit, almost all of them. So that's the reason why somebody who walks into your clinic, if the pupil is involved, then it's a ticking time bomb. And what's the investigation of choice? What investigation would be asked for? What investigation would the patient require? In somebody who has a
MRA.
Exactly, you would like to have MRI brain and orbit with MRA, because you want to rule out aneurysm of the posterior communicating artery. Excellent. Have a look at this patient. What's the first impression? What are you seeing here? What do you see here?
Left exotropia.
Left?
Exotropia.
You're not very clear. Can you?
Exotropia, sir.
Left exotropia. Anything else?
With mild
There's
dose.
ptosis.
Yes, there is ptosis, and absolutely right. There is a left exotropia. Now let's motility. Motility. Concentrate on the eyelid. Patient looking to the left. Look at the left eyelid. Patient looking to the right. Did you observe anything when the patient looked to the right?
Lid retraction.
Yes, lid retraction. So what do you think is happening here?
To answer.
Duans, you'll have a
Limited abduction maybe.
shortening of a palpebral fissure and patient adducts the eye. Here there is a widening of palpebral fissure.
Okay.
This is inverse Duans.
Inverse answer.
So where do you see inverse Duans? So this patient had a third nerve palsy. He says it recovered well, and this is how he has come to you after.
Aberrant regeneration.
Fantastic. So what patient has is an aberrant
Aberrant
regeneration.
regeneration.
What are the other signs of aberrant regeneration of third nerve?
Pseudo-argal Robertson pupil. Pseudo-contrastive sign.
Yeah. First you look at the lid, right? Then you come to the pupil. See what happens when the patient looks down. You'll find that this lid is not following the eyeball. All right, so video is stuck here, but you'll find that this, when the patient looks down again, the ptosis will reduce. Where would you see one Graffis sign?
Thyroid eye disease.
Thyroid eye disease. So that's why it's called pseudo one Graffis sign, when there is a lid lag, when the patient looks down, but it is not because of thyroid. So this is pseudo one Graffis sign. And pseudo ARP is where there's a pupillary constriction that patient adducts this eye. All right, so that's about the third nerve. So please remember, the points to be noted in a third nerve are always first look at the pupil. The second important sign to be examined is whether fourth nerve is intact, because remember third and fourth nerve both are in the midbrain. So is there any concurrent involvement of the fourth nerve? And how do you look for a fourth nerve involvement? The presence of a third nerve is you ask the patient to look from up to down. If the fourth nerve is intact, what movement would you see? Which muscle is supplied by the fourth nerve?
Superior oblique.
All right. So which movement of the
Intorsion.
Very good. So if the fourth nerve is intact in the presence of the third nerve palsy, you'll find that there's an intorsion of the eyeball when the patient looks from up to down. All right. So, and the third important sign that you should always be aware of and look at in the patient who has the third nerve palsy is presence of aberrant regeneration. Now, why? So, aberrant regeneration, three signs we looked at: inverse Duans, where there's a widening of palpebral fissure. There is lid lag in the down gaze, which is pseudo one Graffé, and pseudo ARP or Zernecki sign when there's a constriction of pupil. Now, why these three signs, aberrant regeneration, is important in a third nerve palsy? Any idea? The reason why the aberrant regeneration is important is, remember, aberrant regeneration is almost never seen in somebody who has an ischemic third nerve palsy. So if you find somebody with an aberrant regeneration and if patient did not have an MRI and MRA in the past, then you should always get the MRI and MRA because it can occur in a compressive lesion of the third nerve. Remember also, though, that aberrant regeneration of the third nerve can also be seen in trauma. So two aberrant regeneration of the third nerve is traumatic third nerve palsy or a third nerve palsy because of compression. It is almost never seen in an ischemic third nerve palsy. Let's look at this video. What is the first impression before we start the video? She has bilateral ptosis. Now see what happens when you examine the ocular motility. So patient trying to look to the right. Up, down. So practically there are no ocular movement which are present. But if you see the lids are dancing, can you see the lids are dancing? Lids are down a little bit. So that is called lid hopping. And this is, what is this sign? Patient looks down and then makes upward saccades. Can you see this lid eye is jumping up and going down? So that is Cogan's lid twitch. Patient has a lid hopping, patient has Cogan's lid twitch, and patient also says that mitosis and diplopia is more in the evening. What's your diagnosis?
Ocular myasthenia gravis.
Exactly, ocular myasthenia gravis. So somebody who has variability, somebody who has, please remember, ocular myasthenia gravis will always be in your differential diagnosis. Acute onset or adult onset of ptosis or diplopia. It will always be there in your diagnosis. If the second caveat is pupil is almost never involved in ocular myasthenia gravis. So if you find ocular motility problem with a pupillary involvement, you almost always would rule out myasthenia just because of the pupillary involvement. The signs that you look for is Cogan's lid twitch, where you ask the patient to look down, and then you ask them to make an upward saccade after 30 seconds, and you'll find that the lids are hopping. They go up before they settle down, and that was present in this patient if you have seen. And lid are also hopping. The other sign is orbicularized ocular tone. You ask the patient to squeeze the eye, and with a very minimal pressure, you'll be able to open the eye. And that happens in ocular myasthenia. Reduction of orbicularized ocular tone. You'll also check for signs like fatigability, where the ptosis will increase if you keep checking ocular motility, or if you ask the patient to look up. If you ask the patient to close the eye for 5 minutes and open it, you'll find that the ptosis has reduced. What is the other sign? What is the ICE test? How do we perform an ICE test?
We have to measure the vertebral palpebral height and then place the ice pack for 2 to 3 minutes and again check for the vertebral palpebral height.
Yeah, so you place the eyes for 2 minutes. It is important. It is useful in somebody who has incomplete ptosis. ICE test is not useful in complete ptosis. An ICE test is not useful in somebody who has only ocular motility problem because of myasthenia and no ptosis. These two are the sensitivity and specificity of ICE test reduces. So somebody who has a complete ptosis, ICE test is not as sensitive as versus somebody who has an incomplete ptosis. Also, somebody who has ocular motility problem with no ptosis, you may not be able to rely on the ICE test. So that's about some of the clinical signs of ocular myasthenia. Here again, you'll find, remember, even pediatric age group can come to you with ocular myasthenia gravis. Here, you will find that this kid is not able to move his eyes at all, but you'll find that there can be some lid movement, lid hopping, which can occur when he's trying to move the eyes. So that's one of the signs of a lid twitch, is one of the signs of ocular myasthenia gravis. You can see that the eyes are going up and down here. All right. What's the first impression again?
Bilateral ptosis.
Yes. Now see what happened. Upar dekho. Upar. So here patient is trying to look down. She's trying to look up, right, left. There is very minimal movement in all sides. What do you think is happening here? Bilateral near symmetrical ptosis and a very minimal movement in all gazes. And there is no lid or dancing or hopping. Where do you think is the problem? So this is a classical case of CPEO. What is CPEO?
Chronic progressive external ophthalmoplegia.
Fantastic. So this is, it is generally seen in, the onset is generally in the first or second decade, more common in females. So that this lady had an onset of this problem when she was 13. It slowly progressed. You see there is a bilateral, almost symmetrical ptosis and a symmetrical loss of eye movement. What's the next thing you like to do? If I say I would like you to check the fundus, what is it that you will see in the fundus? So CPO can be associated with pigmentary retinopathy, RP-like pigmentation. So you should look at the fundus and see for the saltpeter kind of fundus. And what is the most important test that you advise this patient? Any idea? All these patients should always have cardiologist consult because they are at a risk of developing heart block. So these patients should get the ECG and should have a cardiologist consult to make sure that they are not. We are moving on and we are reading now one of the last slides. So this is in the 70s. Have a look. There is no there is no movement of the eye. In 70s, no ptosis, but no movement of the eye at all in any direction. Any idea? Remember, when you have somebody who has no movement at all in any direction, you have to think, saying, is this problem coming because all the muscles are not acting? That is myopathy. Or is this neuromuscular junction problem? What disease comes at a neuromuscular junction?
Myasthenia.
Yeah. And the third problem can be supranuclear gaze palsy. A supranuclear gaze palsy also can with complete loss of movement. So there are two groups of disorders: CPO, which is more common, more in females, or myotonic dystrophy, which is more common in older males. Myotonic dystrophy can also have a particular kind of cataract.
Christmas tree pattern.
Fantastic. Christmas tree cataract. So how would you differentiate? Myotonic dystrophy also is seen in older males. This patient also has some problem. Do you say that this is myotonic dystrophy or supranuclear? Is there any? This is the test that you perform. So basically, the test that you have to do is you ask for passive movement. You let the patient move his head when you move the head, and you'll find that the passive movement are present in a supranuclear problem, while they are absent. That's how we differentiate in myopathy control. You can also find ptosis in supranuclear control. You will not find ptosis. Okay, any questions so far? What is you can look there. That is actually the right side. Any idea? So adduction limitation, there is a partial third nerve palsy. The patient had a nystagmus here in the abducting eye. If there is a abducting eye with adduction limitation, what do you patient is having? What is INO? What's the full form of INO?
Internuclear ophthalmoplegia.
Ophthalmoplegia.
And where would you find the lesion if somebody has INO?
MF bundles.
MF bundles. MLF. What is MLF?
Medial longitudinal fasciculus.
Fantastic. Medial fasciculus is where you'll find the lesion if somebody has INO. So that patient actually had INO where there's an adduction limitation and also nystagmus of the abducting eye. So please remember, ocular motility problem can arise because of a muscle problem. It can be myopathies, then it will be seen in both the eyes and symmetrical, or it can be fibrosis or entrapment or inflammation of one muscle. So that muscle will overact and the other muscle, so movement in the opposite direction will be affected. It can be a nerve problem, third, fourth, and sixth nerves. And we talked about the associated nerves that you look at when you see a patient with fourth or sixth nerve palsy. It can be myasthenia gravis, where you find a variability and various lid signs, or it can be supranuclear problem like INO, or that gentleman that I showed you, that patient had progressive supranuclear palsy or PSP. So INO is intranuclear ophthalmoplegia where the lesion is only in the brainstem. PSP, again, there is a brainstem degeneration which gives rise to Parkinson-like syndrome and the problem with the gaze. So remember, ocular motility problem can present, these topics can be discussed either in the Viva, you can get the patients, or you can have a full question or a short question. So these are very important topics, and I have just tried to cover the clinical relevance of all these ocular motility problems. I again thank ABI Institute, Satyajit, Pooja, and the team here, and also Intas people for coordinating this. And thank you so much for involving me. If there are any questions, I'll be happy to take. We have a few minutes left.
We'll wait for some questions in the chat box. The whole session has been so interactive by itself that there are no questions left now. What a wonderful presentation. What a wonderful interaction it was.
Thank you. Thank you. Thank you so much.
So to give a brief overview about this program, this whole program was architected by Dr. Rashmin Gandhi. If you look at me as the producer, the whole director of this whole program was Dr. Rashmin Gandhi. We are very, very grateful to him, not only for today, but for all the days that have been lined up from Monday to Saturday, was all decided by Dr. Rashmin, and we are very, very grateful to you for today's program also, and for the beautiful presentation that you did, and for all the help that you gave us in organizing this program for the entire week. We would like to thank you from the bottom of our hearts. And if anybody has any questions, you can still unmute and ask yourself, or write in the chat box, or else in the next 1 to 2 minutes, we'll wrap up this session.
Lost the connection. There are no questions.
There is one question. Rashmin, can you see that question?
Yes.
When is it INO and when is it 1.5 syndrome?
All right. So INO is where there is a lesion in the logical fasciculus. What happens in INO is that when there is a right epileptic, you find that right reduction that 1.5 syndrome where apart from MLF, the PPRF of the same side. At a point in time, also the passive MLF and PPRF. What happens is when there is a right PPRF, the patient cannot look to the right at all. There is a right face box. The right eye does not conduct, left eye does not conduct. That's what we will talk. Then there is a right MLF. So now right eye is not even able to adduct. So right eye is not abducting, right eye is not adducting. Left eye can abduct and will have a nystagmus. That's why it's called 1.5. One eye is completely gone, the other eye is half gone. That is 1.5 syndrome. 1.5 syndrome is where there is MLF.
Why is there abduction nystagmus in INO?
That's because there is an adduction deficit on one side. The other eye, there is a compensatory more, according to Harry's law, there is a more innervation of both in the left eye. The right eye is still not trying to abduct, and that because of the elastic force of the orbit, will have a nystagmus.
Okay, so we don't have any more questions. So once again, a big thank you. Our grateful thanks to you for this program this evening. And we look forward to the postgraduates joining us tomorrow evening at the same time, 5 o'clock. Thank you so much, Rashmin. Thank you so much, Intas Pharmaceuticals, Manishji and Chandrasekharji, for bringing this all together. Thank you so much, Rashmin, once again. Thank you so much.